joining this independent scientific advocacy group public webinar press conference. And we'll take a brief moment to wish Happy New Year to people in New Zealand. It's just turned to 2021 and I understand they're celebrating with lots of parties. That won't be the same for us, unfortunately. So we've called this press conference, this public webinar today, just because of the urgency of the current situation. As everybody knows, we're back into another lockdown and we very much want this to be our last lockdown. I think people are now understanding that this living with the virus lockdown yo-yo is something quite miserable and we need to talk seriously about a strategy to make this lockdown our last. And so the structure for today is that we're going to hear from different members of the Independent Scientific Advocacy Group. We're going to describe the current situation, show you some projections for what's happening. And we're also going to talk about what needs to be done to make this lockdown our last. And we're very happy to welcome you all here today. And we're also very happy to take questions. And I think you can see there's a Q&A function within the Zoom webinar, and you can type your questions in there and we'll look at them and we'll get to them. And so we're just going to hear now from various members of the group who are going to give very brief introductions and pieces of information before the questions session. So first I'd like to ask Professor Jerry Killeen, who's a professor in UCC, to give an overall introduction and welcome. Thank you, Jerry.
Good morning. Thank you so much, Aoife. I guess I'd just like to explain to everybody, why are we all online here at short notice in the middle of a Christmas holiday? As a group of volunteer experts, we are very worried to a level that we haven't been really, unless we go back to March or April. And why are we so worried? Well, at the moment, we're actually experiencing two oncoming waves, a third wave and a fourth wave. And we need to deal with those in sequence. In brief, I think it's obvious to all of us what our third wave is starting to look like. It may well turn out to be the biggest and nastiest of the waves we've seen so far. I think all of us, all of our colleagues who are working in the health services, they're all experiencing this right up front. The contact tracers are really feeling this. We have to respond as a nation and we have to respond together. I think what makes this third wave even more concerning is that underneath this third wave, there is a fourth wave emerging, and that is a wave caused by this new variant of the virus, which is more transmissible. And, the plan to live with the virus as it was never tenable. It was always going to be a roller coaster or a yo-yo, as different people have called it. We've seen that the illusion that we could maintain it at a steady state, that we could somehow play for a draw and, against a virus like this, has been cruelly exposed already. I think now it's really, really time for us to knuckle down and realize that the only way to effectively tackle this virus is to play to win. Now, if our three waves haven't exposed the illusion of living with the virus starkly enough, we can guarantee you that the fourth wave will do so in a way that we haven't seen before and will be a much wilder ride than anything we have seen to date. It will be capable of overwhelming our health facilities in a way that we just haven't seen so far. And I myself, I got to say, I was slow to react because I thought we had enough problems already. I took a few days to convince myself that actually this new variant is containable. I'm happy to say, I haven't had a look at the numbers, I think it is. But the trick is we have to move instantly. The time for dilly-dallying is over. Any illusions we might have been had that there is a middle road, we have to forget about those. And I think some of my colleagues here can tell you more about the details of the numbers and the solutions, but really it's time for us to move on as a country and to embrace a robust, ambitious plan for aggressive suppression and then elimination of this virus. Thank you very much, Aoife.
Thank you, Jerry. That's perfect. So I'm going to quickly hand over to Dr. Paul Dempsey, who's a mathematical scientist and who's going to present some data on the current situation and projections for the future of the situation in Ireland.
Thanks, Aoife. So just to kind of quickly go through where we are at and how we got here, I have two charts showing the growth in cases and in positive tests. We have to remember at the moment we're about 2,500 positive tests that haven't been reported in the last couple of days, so they will eventually turn into cases as well. We've seen here that the cases really started to tick up around here when the shops reopened, retail reopened. We started to socialize a bit more. Again, at this stage, we don't estimate that the new variant had any real role. If the new variant comes in, these growth rates, instead of being a kind of a growing rate here, would jump up even higher again. We're at the moment, we're looking like among the non-healthcare workers, we have growth rates of over nearly 15%. There has been a drop in recent days, but again, that's mainly because of the lab is not working fully up to full capacity over the Christmas period. And there we see the same thing again, a drop just related to Christmas, but we can see in the tests alone, we're back up to where we were just before Christmas in terms of daily growth rates. Why we want to have something more than just one lockdown is if we go with our current plan of let's have a lockdown till the end of January and let's open up again, we're going to end up with February, and at the end of February having to lock down again. Now this is including taking into account some of the vaccinations. So using our vaccination strategy, we'll have required 3 more level 5s before we get to middle of June. And then we'll try and reopen again near the end of August a little bit, and then fully-ish then in October. But because of the current vaccines and how much they're expected to impact on transmission, we probably won't be able to survive if there's any circulating virus with the kind of numbers we're expecting from the vaccination programs. How to actually do it is we to throw the kitchen sink at it right now as much as we can. That means full lockdowns, making sure our hospitals have PPE to the max, that inside our hospitals we reduce the amount of inter-contact between the staff, canteens, break rooms, training that's not required. Any staff members that can do their work remotely from IT, HR, all the other facilities that are currently in our hospitals have to be tried to facilitate to work from home as soon as possible. That's kind of our plan to get it down to as quickly as we can, and we think we can achieve this before March if we put in all of our effort right now. In our long-term plans to make these things go even faster, we have working with some American colleagues to design systems where we can split the country into certain areas that will allow us to get back working as quickly as we possibly can. These are kind of green zone strategies, and Professor Yunir Banner M is one of the designers of this, and he's on the call for later. Thank you.
Thank you, Paul. That's really good, and I think it's really quite terrifying to see the prospect of so many more lockdowns unless we act now to make this our last, and that is really what's motivating all of us here today, I think. So I'd like to now call on Dr. Oisin O'Connell, who's a respiratory consultant in Bon Secours Cork, to give us some of the clinical perspective.
Thanks, Aoife. I suppose in general, my sense of where we're at is I'm kind of comparing this to a marathon or kind of a football match, and I feel we're entering the second half of both a kind of mile 13 of a 26-mile race. So what we've done up to now, we essentially have to repeat both psychologically, physically, emotionally, and all the usual kind of sports terms, grit, determination, and stamina are what we're all going to need. And I think people are lashing onto the vaccination as a clutch to the solution to all of this. But as Paul's just outlined, we've got another 9 to 12 months to go of this, and we still have to be very clear that we can get the best outcomes with the resources we have, and being strategic, which we haven't been to date, and actually having decisive action as to what that strategy is what we're going to need. In terms of where we're at, in terms of the
Oisin seems to have a little connection problem there.
Irish healthcare system found a reduction. Can you hear me?
Yes, I can now, sorry.
Yeah, sorry, it was somebody ringing through. We've got a reduction in noroviruses, reduction in influenza, and as a consequence of that, we haven't seen the surge in winter bed capacity that we see with other viruses and the effects on asthma, COPD. What we're trying to avoid is the situations that have gone on in London, Los Angeles, Bergamo, where they're running out of oxygen in London at the moment. The ICUs in Wales are looking for people to help, medical students to help with proning patients. So they've put a call to arms. We're about 2 months behind Wales and UK. So this is where we need to double down on all the measures. We've seen that they're using freezers outside hospitals in the UK, in Wales, and in America at the moment because of the speed at which death is coming upon them over there. So that's what our ultimate aim has to be. Similarly, from a hospital environment, we're starting to see outbreaks on the wards. We're seeing significant losses in both healthcare professionals, nurses, doctors, and allied health professionals. And on top of that, unfortunately, we've seen a mass exodus of healthcare professionals to Australia and New Zealand for January this year, and a reduction in the number of people coming back. So in terms of hospitals, we run 2 pathways in hospitals. We run a COVID pathway and a non-COVID pathway. Essentially, the COVID pathway is a much slower throughput of patients, meaning we have to put PPEs, masks, gowns, and it takes a lot longer to see any individual patient on the COVID pathway. We're still preserving healthcare in terms of we're still looking after heart attacks, we're still looking after all the regular stuff hospitals do, and we're trying to do that in as safe a way as possible. And what we're also finding is people are starting to ignore symptoms and present later, which is what we don't want. We still do have bed capacity, but we have to pay attention to the ability of the health service to run 2 concomitant services, to run the COVID pathways and the non-COVID pathways. And what's happened in England, Wales, and USA, because of the speed of COVID, and as I say, our last level 5 lockdown bought us some time, only in the order of 6 or 8 weeks until it starts happening to us. But they've started cancelling all sorts of things like transplants. They're not doing kidney transplants. They're stopping doing heart and lung transplants in the UK. They're stopping doing coronary artery bypass grafts, esophagectomies. And what people may not realize is that one coronary artery bypass graft patient might spend 2 days in intensive care, whereas a severe COVID patient might spend 10 to 14 days. So if you think of ICU bed utilization capacity, when your ICUs fill up and reach capacity, it means that 6 or 7 patients can't undergo a coronary artery bypass graft for the same patient that would otherwise have gone in there because a COVID patient is occupying. So it's not just elective procedures that get affected when your ICUs reach maximum capacity. It's your ability to run life-saving, time-critical surgeries. And that's where I think we need to all double down on our self-discipline.
Thank you, Oisin. Very important to hear that particular side of things. I'd like now to move to Dr. Andrew Kunsman, who's from Queen's University in Belfast, is going to give us a little insight on the situation in Northern Ireland. Thank you, Andrew.
Thanks, Aoife. So the situation in the north is increasingly dire at the minute. We have seen hospitals being full for the last few weeks, and I think the situation is only going to get worse for the next few months. I think we face a very difficult few months in the north. Yesterday saw the record number of cases with almost double what was seen in the previous wave. However, the long-term situation could be more optimistic. We've got 6 weeks of restrictions that have begun, and the public mood is really shifting towards elimination rather than living with the virus, which seemed to be the narrative before. Whilst complete elimination will be a bit trickier in the north than in the south, we did managed to achieve manageable numbers of local cases in the summer until imported cases began to pose a problem. However, with vaccinations being rolled out, the task of keeping them low will get easier if we manage to control it using the public health resources available. If there are no cases coming up from the south, then that task will be even more manageable, particularly for the all-important border counties. And there should be a reciprocation in benefit. If one part of the island pursues an elimination strategy, then that will make it easier for the other part and will help itself in the process. Leadership in the south is crucial to this. If they take control and go for elimination, that would put an enormous amount of pressure on politicians in the north to follow suit. Businesses here will not want to face rolling lockdowns if their southern neighbours are reopen and booming. We face a real opportunity to avoid further lockdowns through coordinated action. We can support the hotel industry to quarantine visitors or returning tourists from countries with high cases. So I really think that despite the situation at the minute not looking good, that there could be light at the end of the tunnel if we take action now. But it will require the same amount of leadership shown in March, but with a greater focus on preventing the importation of cases from abroad. So I really think if we knuckle down, that we can make this lockdown our last.
Thank you, Andrew. I think the mood change is something we're feeling as well. I noticed that The Guardian called for a zero COVID approach. We saw Roisin Shortall of the Social Democrats just saying she wanted a near elimination approach. And Tony O'Brien, former head of the HSE, wrote a very good piece in the Sunday Business Post last weekend saying that, you know, it's time to take an elimination strategy. And like you say, it'll be easier if we go together on this. And I noticed some of the questions that are coming in already, which we will get to, are to do with the border and how we manage this coordination north-south. So it's a very important angle. I'd like now to move to Professor Tomás Ryan, who's a neuroscientist in the Department of Immunology and Biochemistry in Trinity College, who's going to talk about the significance of this new UK variant B117.
So obviously the new variant, there are a number of new variants for this particularly salient variant of SARS-CoV-2, which seems to have arisen in England and is currently also in Ireland, is coloring the story for how we're examining where we are and where we're going after this. The feature of this variant is that it seems very clear that it is 50 to 60% more transmissible than more typical wild type strains of the coronavirus. It doesn't seem to be more virulent. It doesn't seem to result in increased risk of hospitalization or death, but left unchecked can obviously result in far more deaths by being transmissible much more easily. The issues of how this poses a threat to us going forward are numerous. It means that lockdowns are going to have a weaker effect. So being essentially in level 3 may not keep the R number below 1, and we may need greater restrictions to have the same degree of efficacy. There's a much greater risk of slipping backwards whenever we make a mistake. Obviously greater risk of overwhelming the health service. And currently we're in a fourth wave. We don't really know what the dynamics are of this because we've got two parallel viruses in the community. What does seem clear at the moment, and this may be contrary to some of the narratives that we're hearing from government in Ireland, is that there's no reason to think this new variant has contributed to the current situation we're in. That is, there's no reason to think this has significantly contributed to the third wave in Ireland. We heard from Dr. Cillian de Gaskin of the National Virus Laboratory on December 24th that unpublished preliminary analysis of viral samples in Ireland suggests that about 10% of cases in Dublin and in Wicklow and possibly in Wexford have this new variant of the coronavirus. We don't have knowledge currently beyond that, but the infection rates amongst people who are under the age of 15 do not seem to have significantly increased. And this would suggest that this particular variant has not contributed significantly to the current wave in Ireland. The situation in Northern Ireland may be different. The United Kingdom have a much greater surveillance net on the virus than we do, including genome sequencing, analyzing the entire virus, and PCR screening. In terms of genome sequencing, it's true that currently there are only 7 genomes of the new variant identified in Ireland and 1 in Northern Ireland. However, with PCR screening that was done at Oxford for the week of December 14th to December 18th, on a small and preliminary sample, so this data needs to be viewed carefully, it could be that up to 50% of cases in Northern Ireland right now are of this new variant. And obviously, there's a risk of this spilling over the border, but these data need to be confirmed. So the main thing to conclude is that this virus, this new variant, is in Ireland. No country knows how to control it. We don't think it's contributed to the current wave, which can be explained purely by social behavior over the Christmas period, but it very much changes the story about how we have to manage things going forward.
Thank you, Tomas. Okay, so I think now we've got a kind of a picture, an overall picture of various angles of the current situation. I'm going to ask now Professor Sam McConkey and then Professor Anthony Staines to each give a view of what kind of 2021 we are looking at. Paul has already touched on this with his models, but just another way, what are the options and what are the alternatives for 2021?
Thanks, Aoife. My view is that many of the folk in Ireland now who have been living, as in Leo's words, living with this now through 3 waves in 2020, have realized that this is not a pleasant way to live. And this trying to run a business when you have unpredictable opening and closing is exceptionally difficult, whether it's a restaurant or any sort of business. So the choices I think before us are more of the same, where we have ongoing level 3, level 5, level 3, level 5, and perhaps even a level 6 if things get worse as one choice. Or the other choice is to really follow what has successfully been done in areas of the world where about 1.6 billion people live. So this is not an unproven idea. It's something that many countries and some small countries in European islands have done successfully that we can choose and try to do and succeed, I believe, in doing over about 2 to 3 months. It does involve the coordinated activity, not only of the 5 million people that live here, but also obviously the people in Northern Ireland. There are several positives coming out of Northern Ireland. So on just before Christmas, they agreed to restrict travel into Northern Ireland from Britain by asking people coming into Northern Ireland to restrict their movements for 10 days. And that's the first time that Northern Ireland has really done that. That to me is really a sign that the folk in Northern Ireland have realized that this is an existential challenge to their life and society as it is ours. So working together with them, I think we can do this very successfully.
Thank you, Sam. Yes, that's what we need to do. I'm now going to ask Professor Anthony Staines of DCU to talk specifically about, so for 2021, but especially about the vaccine and the vaccine rollout. And I know a lot of people are asking questions about the timelines and why it takes as long as it takes.
Thanks very much, Aoife. There are a lot of unanswered questions about the vaccine rollout, and that's partly because there's huge uncertainties about supply. It seems likely that the main issue is going to be access to sufficient supplies of vaccine rather than the pure logistics of giving them out. There is a substantial piece of work that HSEs still have to show they can do, which is to develop the systems to record who's got a vaccine, have they got a second dose, when is the second dose due, that they're going to get their second dose. So there's a fair piece of work to be done there. At the moment, we would be pretty confident, unless things go very, very badly indeed, that we will have 80% vaccine coverage by the autumn, perhaps by October. In terms of opening up society, in terms of backing out of the restrictions we live under now, it's likely with the existing strain of virus that we have to get to 80% coverage. With the new strain of virus, if that becomes the dominant strain, as is certainly plausible, nobody really knows what proportion of people we have to vaccinate. It could be as high as 90%. It's probably not as high as is the case, for example, for measles of 95%. But until we get a very high proportion of our population vaccinated, life does not go back to normal. And that is going to take a substantial amount of time. The government has been very vague about their expected timelines. And this is partly because actually nobody really knows. But I think for a business, it is imperative to have the best guidance you can. And the hospitality industry are all saying the same thing. What happens in summer 2021? Because summer 2020 was very, very bad indeed. So is summer 2021 going to be the same? Or are we going to be in a position where even if we don't have foreign visitors, which may well be the case, but the locals can go on holiday freely around the island of Ireland? And that will help all those businesses, all those jobs to survive to the end of 2021. And remember, these are major employers in areas where there's not much in the way of alternatives. These are major employers in small towns. These are major employers in rural Ireland. And there are not many other major employers in many of those areas. So it's very important that we sustain this business, that we sustain this particular industry. Thank you.
Okay, thank you, Anthony. Okay, so far I think we've seen, we all understand now we're in a very deep crisis, probably our deepest crisis yet in this pandemic. This was an avoidable lockdown, but now it's a necessary one. And we have to make sure we avoid further lockdowns. Every lockdown since the first one has been avoidable if we had taken the correct steps. So now we must take those correct steps now to avoid any future lockdowns for 2021, because as we've heard, the strategy of waiting for the vaccine is allowing sufficient time for maybe 3 more lockdowns. So now we're just going to talk briefly about the various aspects of this strategy that we think are important. This is going to be brief, but we're very happy to elaborate on this with questions. So I'm going to first call on Professor Patricia Carney from UCC, who's going to talk about track, trace and isolate and the importance of that and how it can be supported.
Thanks, Aoife. So I suppose it's important to state that outbreak management and contact tracing, which we now hear about with a number of contacts on the news every day, is something that our departments of public health have been doing for years in terms of controlling infectious diseases and managing outbreaks. The problem at the moment is the sheer scale. So we know we went from sort of 200 cases at the start of December. Those people had an average 3 contacts, so about 600 people a day that needed to be contacted. Whereas now we're up to 2,000 cases with 5 contacts on average, so 10,000 people. So we know really we need these kind of drastic measures of a lockdown to manage that. Our public health, in public health, if the scale of that is really out of control. So we need these severe measures to get the numbers back down. And we've seen with the previous lockdowns that because people have adhered to the restrictions, we know that we can get those numbers back down. And then we can allow our contact management program in partnership with our local departments of public health to really manage the outbreaks. And that's not just about isolating the cases, tracking down the contacts and getting them to restrict their movements, but it's also about doing work around source investigation. The problem with COVID and why it's been so difficult to manage is that a large proportion of people have low levels of symptoms, and some maybe symptoms that they don't even consider are anything out of the usual for them. So they don't pop up, they don't go to the doctor, they don't get tested, and then they can start these little fires that can spread out into the community. So what we need to do differently this time is get the numbers down to a level where then the local departments with the contact management program can really work on controlling the numbers to a level. And then we need to do the other things that we're going to talk about to avoid having ongoing inward importation of new cases.
Thank you, Trish.
Thanks, Aoife.
I'd now like to move to Ivan Perry, who is a professor and public health doctor, and he's going to talk about what's needed in terms of resourcing the public health doctors in order to achieve this, non-lockdown version of controlling the virus. Ivan, sorry, you're still on mute.
Thank you, Aoife. So I'd just like to say a few words about our public health doctors and the department of public health medicine. The public health doctors are the unseen frontline workers in this pandemic. They have been stretched to breaking point and beyond in recent weeks, as indeed they were in March and April of this year. It is now absolutely essential that the issue of consultant status for these doctors who are actually trained to consultant level, it's absolutely essential that this issue is now resolved. This issue has been under review and contested for over 20 years, and now is the time for the Department of Health and the Minister, and I would call on the Minister to do what is needed now to finally resolve this issue in the midst of the most serious public health crisis in over 100 years. We also need to ramp up in investment in infrastructure and staffing for the public health medicine departments. As we know, there is a lot more to controlling an outbreak than setting up a contact tracing call center. We urgently need to recruit, train, and support public health scientists to work alongside the public health doctors in our departments of public health medicine. The effects of neglecting our public health infrastructure over decades are now plain to see, and now is the time to act.
Thank you, Ivan. Yes, I fully agree with you there. So I'm now going to call on Professor Yanir Baryam, who's president of the New England Complex Systems Institute, and he's going to give us an international perspective and also address the importance of quarantine and international travel. Thank you, Yanir.
Thank you. Thank you. Yeah, so there are a couple of things. One is that it really has been learned from many places that having 14-day quarantines for people who are arriving from out of a country is super important to being able to control an outbreak. And so this really has to be something that becomes incorporated as part of the strategy. And it's not enough to just limit, to apply quarantines to people who are coming from the places that are having the new strain, i.e. the UK and South Africa. It's really important to do that for everybody, not to import new cases of both, both of the new strain and of the many other strains that might happen or have already become part of the accepted set of viral strains or variants. And in terms of the other point that I would make, and Jerry said at the beginning, that he's convinced himself that we can control the new variant. And I'm also hopeful that that is true, but I would say that we haven't demonstrated it. And the fact that we haven't demonstrated it should be very scary, because this is a situation where even with the existing severity of illness and death rates, to have a strain, variant that we cannot control would be devastating. So we really should be throwing everything we can at stopping the outbreak entirely and making sure that we can control it and using all of the tools that we have available to us. And so I hope that the country and the policymakers will realize that this is something that we have to do immediately.
Thank you, Yanir. Yeah, I think we have a lot of lessons to learn from what's best practice internationally. And like we say, there are countries celebrating New Year's Day and New Year's Eve very normally right now. So I'd like to move now to Dr. Nessa Cronin, who's a lecturer in Irish Studies in NUI Galway, to talk about where do we go from here.
Thanks very much, Aoife, and good morning to everybody from the west of Ireland. Just a very few brief comments, reiterating, I suppose, lots of different discussions and debates we've been having since March, really. But I think at this juncture, as both Aoife and Ger said at the beginning, that we're kind of really at the end of the road of magical thinking, and that we need to realise that the reality now that we're living in is the reality of the virus. So no amount of speculation about if we do this or if we do that is going to actually translate into the reality. The virus operates on its own reality, and that's what we need to align ourselves with. From the beginning, we've been arguing at ISAG that an all of society problem demands an all of society solution. So it's not just enough to individualize responsibility or blame, but we really need to have, at a time of a global pandemic, foregrounding the role and the responsibility of the state and of political leadership. A successful public health system is directly related to a flourishing society and economy, and we've seen those arguments play out in recent months as well. Parts of what we need to really address for 2021 is that we need more joined up decision making, and in particular a balance of expertise and experience. And I'm thinking here in particular of gender balance. This is one key issue that came up in the earlier phases of the crisis. But also of geographical balance. And again, ISAG is a great example of how cross-border communication and learning and expertise can work to address these issues. Professor Gabriel Scally in our previous press conferences had also been arguing for an all-island approach for this, and for North-South ministerial committees to work towards looking at this on an island basis and looking at the island of Ireland as an epidemiological unit as well. On a more personal note, I suppose, my son Creeving was listening to the radio the other day. I tried to turn down the news when it comes on at 1 o'clock and 6 o'clock at home. And he said, Mum, I said, I heard Ireland is second in the world in terms of the UN, in terms of being one of the best places to live. And his first question was, why aren't we number one? And it wasn't, aren't we great? He said, why aren't we number one? And I think for me, that message of ambition is something that we need to actually strike a chord with now. We need to be ambitious for our children. We need to be ambitious for our elders. We need to be ambitious for ourselves. We need to be ambitious for our students, our healthcare workers. We need to be ambitious for our colleagues and our friends in direct provision centres. We need to be ambitious for our citizens in the prisons across the island of Ireland as well. And it's that kind of ambition is what we are actually calling for right now. We have great form in Ireland with this. I teach and work in Irish Studies. We have seen in terms of public health measures how the smoking ban became global headlines, but also recently the different referenda that we've had in Ireland and the importance of the citizens' assemblies in terms of the marriage referendum and others also made Ireland a global leader in terms of rethinking how a good society can operate in the future. And so I think we are at a really critical juncture here now. There is a possibility of North and South alignment. There is a possibility of political will aligning. There is definitely public will aligning across the realization that rolling lockdowns is no way to be living for 2021. We need to get into an elimination, active suppression strategy with all of the different toolkit and all the different instruments that my scientific colleagues in ISAG have outlined very, very clearly. And finally, just as a student of mine said to me just before Christmas Eve, and she's a girl who was hospitalized over the summer, she said, Nessa, I don't know how many more lockdowns I have left in me. So we really, really have to make this our New Year's resolution. Let this lockdown be our last national lockdown. Thank you.
Thank you, Nessa. Yes, very important points there. So finally, I'm just going to call on one last person before we go to going through your questions. I think some of our questions have been answered along the way. So I'm going to call on Professor Julian Merciel from UCD, where he works in geopolitics, and he's going to talk about political strategies to try and achieve this, and also some of the issues around the border. And I know this has been coming up in questions as well. So over to you, Julian.
Yeah, hi, I'll just take like a minute, no more. We have a great plan. Great plans go nowhere if they don't have social support and popular support. So you see 12 faces or so on the screen today, but we've been in extensive discussions with political parties, business groups, trade unions, and others. So we have some support. When we talk to people, the first thing that is striking is how much more support we think we have than we thought we had. From businesses in particular, people understand that yo-yo lockdowns is a ridiculous strategy. It doesn't work for health, doesn't work for economy. And so if you are an individual who works in healthcare or business, if you are a representative of a group, we really invite you to join us. We have the Social Democrats who just endorsed our strategy. People Before Profit as well did that a couple of months ago. And businesses as well, of course, are needed. That's what's going to convince the government to move towards a better strategy. So get in touch with us and we'll talk. Did you want me to say something about the border right now, or?
I think it would be useful because it's come up in a few questions, so that a few people asking about, should we not be moving as a single island is one question. What about identity-based border bubbles that Jerry Killeen mentioned in his Irish Examiner article, and other people just asking generally about the challenges around the border.
Okay, so the border is the question you get all the time. What about the border? Your plan doesn't make any sense because of the border. First thing to say is that, of course, it's better to have an all-island strategy. And just like it would be better to have an all-Europe strategy or a global strategy, right? But so we work on that, trying to make links and coordinate. But you need to have a fallback plan. It's already tough enough to convince one government, let alone two governments. So we start with the Republic and we leave open the door for cooperation. The way to deal with a border, again, is very easy. All that stuff is very easy because all you have to do is copy what they did in other countries where they were successful, like Australia is a good example here. So bubbles means that when you want to manage a border, to reduce traffic across a border, it doesn't really work well if you cut everybody from, stop everybody from going across the border, people who cross the border every day. So you want to have bubbles that straddle the border, let's say 10 kilometers south and 10 kilometers north or something like that, depends on the local specifics. And you allow those people to cross the border freely, to go to school or to work or whatever. So those people live in a bubble and it's fine, you let it go. But to get in the bubble, then you can restrict movements from outside the bubble and from the bubble to outside the bubble, because if a location, a bubble or a county is highly infected, you don't want to spill over to infect other places and vice versa. So that's all it is. The specifics, again, have to be dealt with, based on the places you're talking about. It won't be the same plan for Donegal or for another county. But essentially, that's what they did in Australia, worked really well. It's not easy. It needs, the Garda, for example, the HSE to get together and to explain to people what the plan is. But once you do that, at least you've done all you could, and it's quite obvious that it would bring significant benefits. So that's the overall idea.
Thank you, Julian. There's a question in here now. Somebody is commenting that a couple of days ago, Tánaiste Leo Varadkar said that restrictions could be lifted once elderly and healthcare workers are vaccinated. And this person would like to ask the panel, what would be the outcome of this if this was done? So I don't know if either Anthony or Paul might be best placed to answer that one. And
Maybe, perhaps if I start here, one of the reasons we vaccinate everybody is to protect people who don't mount an effective immune response. There are many people like me who are immunosuppressed for various reasons, who are at great risk of not responding to a vaccine, but also great risk of getting seriously ill if they become infected. And we try to suppress circulation of the virus in the community to protect those people. We do the same for measles. Most people who get seriously ill from measles are babies under the age of 1. And I have ventilated babies with measles earlier in my career. It's no fun. We vaccinate older children because you can't vaccinate under 12 months for measles. We vaccinate older children mainly to protect babies from measles. So that's one example of the strategy. And Paul might like to move on from there.
Paul, could you would you be comfortable talking about, what might happen if we open up just after these narrowly defined groups are vaccinated?
Well, again, I suppose some of our commander here as well. If you look at the hospitals and ICUs, they're primarily in most of the cases that are intake are actually under 65. So our ICUs and hospitals, even if there was 100% uptake in all of our over 65s, would still be overrun in a period of 6 to 9 weeks. We have to remember as well, just for perspective, all we got in March to April was because of around 3 to 4% of our population being infected at most. The limits you're talking about, the new strain, are maybe 20 times that could be infected, all in a very, very short period of time. So that's one. And again, there's the issue as well with the current vaccines, the Pfizer vaccine, and there's no data on whether it actually stops transmission. The AstraZeneca vaccine is not going to, and that's what the model was based on, and what the Israelis used in their vaccine model doesn't allow for a return to normal, even at the kind of optimal 80% coverage. But there are 2 vaccines on the way that do look likely to stop transmission. But again, that'd be more for some medical person, like if Sam is still on the call, or.
Sam, do you want to answer that just with regard to the vaccine, how the vaccine protects people, whether it's protecting against the disease or protecting against transmission?
So thanks, Aoife. It's helpful in our minds to separate what we know confidently based on data, which you can rely on, versus what we hope for or hope might be the case. And what we know about the Pfizer vaccine is that it prevents certainly mild and moderate disease in young, healthy people from 18 to 65. There's some hints it also strongly protects against severe disease and also works in people in their 70s and 80s. But that's relatively small numbers for the latter 2 things. As Paul has just said, there's no evidence that it prevents transmission or provides any herd immunity whatsoever yet. And the reason is because Pfizer didn't design their trials with that in mind. They wanted to protect disease and illness, and that's fine. That's a good goal, to prevent illness, death, and disease. So they haven't yet produced evidence for that. I'm hoping, they're working on it, and I'm hoping within 2 or 3 months we'll know that, but it's not at all guaranteed. Some vaccines are better at preventing disease and less transmission blocking. Others are more transmission blocking. So I'm hoping we'll have 4 or 5 vaccines after a year or 2, and that some will be very good at preventing transmission. None of these provide a solution for us in the next 6 to 9 months that is going to be reliable at this stage, which is why I'm here advocating that we really control this virus in the way that about 1/6 of the world's population already has, and we get rid of COVID community transmission completely from our island and then open up domestically.
That's definitely the most attractive prospect. Jerry, I think you wanted to come in here. Oh, maybe Jerry has frozen. Oh, okay, it's bad timing there. Okay, so I'll move on. There's another question here from Senator Cromwell, who's asking, he's saying he's getting these kind of unfortunately poorly informed messages regarding the PCR tests and that they're flawed and this virus is just a bad flu. And he's asking, how can we give some advice on how to silence this dangerous misinformation? So I see, Sam, you're raising your hand there.
Well, I'm happy. I get lots of these as well, and some of them from people I know. I strongly believe in the importance of free speech and the importance of people being able to dissent. I'm a strong advocate of dissenters. In fact, we here in this call may be dissenting from the government voice at this point. So I don't think it's silencing them that's the answer. I think it's engaging, it's replying, it's saying, talk to the people you know who work in the health sector in Cork, in Dublin, in Galway, all over the nation, and listen to the local voices about what they're seeing with people with COVID-19 and SARS-2 and how they're using PCRs to accurately separate out what we heard earlier on in this call, the non-COVID pathway from the COVID pathway. That use of a rapid PCR coming into hospital helps us to separate out those two and keep one group safe from the other. So those of us actually working and caring for people with SARS-2 and COVID-19 are using the tool in a really valuable, useful way and have been doing so since February. So those folk need to talk and listen to the local people. Some of it's coming from abroad. It's all this sort of mishmash of things from other parts of the world where there's very different political agendas, that some of them may be nefarious, some of them may be malicious, some of them may be even, you know, bots that are just trying to sow anarchy and dissent in our liberal democracy. So I would encourage you to link with those people, talk to them, engage with them, be a human being back to them, and reflect the need for them to talk to the people around them.
Thanks, Sam. I think Jerry Clean wanted to come in here as well.
Sure, yeah. I think if you look at the history of public health, you know, there's always been a 5 or 10% that, you know, just, you know, you can't reach. There's only so much you can do. I think we've seen in this pandemic that, you know, very small numbers of people who don't buy into the societal, you know, the social contract, who don't consider themselves part of the big us, our society, can actually get the rest of us all into an awful lot of trouble. You know, I think most people in Ireland didn't go to a pub, didn't go to a restaurant, and didn't go to a gym over the last month, right? But you've seen the devastating impact that a small minority can have. Now, most people can be reached and reasoned with, but always in the history of public health, there has been a 5 or 10%. And as a nation, we're going to have to be prepared to actually do something about those things. Dermot Dorgan told me a great story about, you know, when he contrasted our culture with Australia, he told a great story about being warned about not having a bell on his bicycle. And sure enough, the police fined him $408 for not having a police, you know, just having a bell on his bicycle. And, you know, we need to go there. It's time.
Thanks, Jerry. Oisín, I think you wanted to come in there as well.
I just want to get back to 2 points Senator Crowell highlighted. One is the single island approach and getting political willpower. To me, I would regard this as getting an all-Ireland approach from politicians as being as important as the Good Friday Agreement. There just hasn't been any political willpower or determination or a cohesive strategy. I think we entirely had this opportunity in around September to achieve elimination in Ireland. We were having very small controlled COVID numbers, and we completely dropped the ball. It was as if we didn't have that opportunity. And we now have an opportunity where the north of Ireland is going into a 6-week lockdown. Ireland is entering a 6-week lockdown. And for the greater good of the nation, we can certainly get a much better outcome for 2021, both economically and healthcare wise, by having a cohesive strategy. But that does bring into account the need for things like border control, central quarantine, strict enforcement in quarantine. In regards to the PCR and the flu, and we get this a lot, and it seems to be on the Twitter media. I mean, the COVID, one, from a respiratory perspective, it gives a very particular type of pneumonitis or inflammation of the lungs. It's very, very different to the flu, meaning it's a kind of a consumptive process where you got inflammation throughout the lungs. They have extremely high oxygen requirements. They are extremely low level of peripheral oxygen, and that has all particular consequences which we do not see with the flu. And to put that into examples, in UK, in London at the moment, there are hospitals running out of oxygen. We've never in the history of medicine had hospitals run out of oxygen, which has happened in Italy and is happening in the UK as we speak. That doesn't happen with a flu. Similarly, we're seeing mass freezers outside hospitals in London. We've seen it in New York, we've seen it in Los Angeles, where the speed at which the death rate is occurring in hospitals. We talked about 1,000 deaths a day in Germany over the last few weeks. Even a month or two ago, they were talking about a peak of predicted of 600, and they're already at 1,000 deaths a day in Germany at the moment. So those kind of things do not happen with the flu. And that's where understanding of exponential curves is important, because, you know, if I think we dropped the ball in the understanding of exponential curves back in September, and this is what the doubling time is. This is exactly how exponential curves behave. And I think a lot of the conspiracy theorists don't have any clue about how exponential curves. I might quickly mention one thing about data, because it was a separate question that James asked on the Q&A. he was asking about the source of data. So the Central Statistics Office have 7 independent sources of data. The Department of Health have a few extra things on top of that, including information from kind of GPs through GP Buddy. And a lot of that data is updated day by day. I know from the ICU, the National Office of Clinical Audit have an ICU subcommittee, and they tell the HSE on a daily basis how many ICU beds are free, and what the number of ICU beds are, and also what number of ICU beds are preemptively booked for surgeries such as coronary artery bypass grafts, lung cancer resections, and all those time critical surgeries that require an ICU bed. So, you know, that is all has to be factored into account. So it's not just a matter of knowing the number of ICU beds in the country, but it's also knowing about who's going out of an ICU after a coronary artery bypass graft after they're stabilized, and who's coming into it because they're preemptively booked for a coronary artery bypass graft, and there's planned elective intubation, that those patients are staying intubation post-surgery. So that data is going through the CSO, and the Minister for Health has given them authority for getting that data out. And yes, they are using air codes as part of that. So that was just an answer to James's question on the system.
Thanks, Oisin. I'd like now to go to Gabriel Scally, and who has joined us. I'm very happy to say Professor Gabriel Scally, who many of you will know for his excellent reputation in public health, and he's also a member of the UK ISAG, which has recently been calling for more stringent lockdowns there, or stringent restrictions there. Gabriel, we've been discussing how Ireland needs to take a different approach if we want this lockdown to be our last, and what we need to do in order to ensure that we don't end up in this situation again in just a few weeks.
I think we are at a crucial time, and apologies for joining you late. We are at a crucial time in these islands as immunisation is starting to roll out, but you may already have noticed today there's a great deal of controversy breaking out in the UK about how vaccines should be used and how effective they are going to be. And that's some very difficult discussions and difficult principles to be worked out there. And the government in the UK, I think, is in danger of getting it very badly wrong here. But nonetheless, it is a game changer and a very welcome one. But it does reinforce the necessity of getting the basics right. Very often, I think, the UK government has adopted the approach of being reactive rather than preventive, waiting until things get so bad that they have to intervene and they feel they have the public support, rather than preventing things. And one of the key aspects of this, and it's an important aspect to note because it affects North, South in Ireland, is their failure to put in place a find, test, trace, isolate and support system. And that system actually becomes more important now because we will see as with most infectious diseases, once you start to get them under control, it becomes all the more important to deal effectively and efficiently and rapidly with clusters and outbreaks as they happen. And we just don't have the system in the UK or in Northern Ireland to do that. And one of the key differences, which isn't explored enough, is the issue of contact tracing. And the advice from the European Centre for Disease Prevention and Control is very clear, and it's exactly the same as the advice from CDC in Atlanta, which is that when you find close contacts, those at high risk, what you should do is test those people. And that is not what happens in the UK. They're not tested. What happens is that particularly in Northern Ireland, where their contact tracing is they talk about a digital first approach, which is a digital only approach to all intents and purposes. So people get a text telling them to self-isolate, and if they develop symptoms, to come forward for testing then. So we miss out enormously in terms of finding people who may be asymptomatic or oligosymptomatic transmitters of the virus. And it becomes all the more important to have a really effective system. I think the other thing where the system in the North and in the UK is falling down is in the absence of support for people who are being tested and having to self-isolate. And very many people are not coming forward for either testing or not obeying advice about self-isolation because they simply cannot afford to do so. They need to work to support their families. And this is a really major problem, and it's why the virus is deeply ingrained in some of our most impoverished and economically and socially communities. So there is a huge bit of work to be done, I think. If one's talking about a north-south cooperation, very important to have that now. The death rates comparatively of the Republic of Ireland and Northern Ireland for this second wave are astoundingly different. And there needs to be, someone needs to speak up and say why that has happened. And a good analysis of why that has happened will give us the clue about what needs to happen across the island to improve the situation. Of that, I'm quite clear. And one of my calls has been for the north of Ireland to invite external experts to do a rapid review within a matter of days of what is in place in Northern Ireland and what needs to be in place in Northern Ireland. Because the situation, I think, is extraordinarily difficult, as it is increasingly across the UK. Independence Age called a long time ago for really serious social restriction, and that hasn't happened. The Tier 4, under which most of the country is now, has been shown to be ineffective in most places. Only in some places has it led to a reduction in levels of infection. In many Tier 4 areas, infections continue to increase, and we now have apparently no other tool in our toolbox except putting places into Tier 4, which we know hasn't happened. Similarly, schools, there's a determination to keep schools open, more or less, which we absolutely agree with. Independence Age wants to see schools open, but we want to see them open safely. And that means taking advantage of the time that we have to put in measures in place, taking over extra buildings and support, employing extra staff to achieve social distancing in schools. We also really want to see a lot of effort and money put into ventilation. Ventilation is extraordinarily important, particularly with this new variant and its increased infectivity. All that does is reinforce the need for the basic public health measures that have not been put in place. So I think we're in a very, very difficult position, and particularly as Oisin was saying, in terms of the health service potentially being overwhelmed and us seeing really terrible scenes. And one of the major problems being the spread of the virus in hospitals and between staff, and large numbers of staff, every day, large numbers of staff being told they have to self-isolate. It's a really, really dangerous situation we're in. Sorry for being so pessimistic on the eve of a new year when we should be being optimistic, but there's a lot of work to be done still.
Thank you very much for that, Gabriel. I think we appreciate the realistic and I think that's what we have needed, and it's possibly been lacking in a lot of the political commentary, because we've had too much, let's say, a surfeit of optimism, which has led us to be misinformed and not really understanding what we're in for. So I think we need that. I think the point of schools is coming up again and again, and I see that Ivan wants to join in, and I think Yanir as well. So Ivan, I'll go to you next.
Yeah, just a very quick picking up on the point that Gabriel has made about North-South. We need to remind ourselves that in 2003, in response to the foot and mouth outbreak, we instituted North-South and East-West controls, and it beggars belief that we cannot do that now.
I agree. I think Yanir, maybe you can talk a bit about schools in general, and then we should also, I think, have maybe an Ireland-specific point of view on the schools. But Yanir, if you could give us a general perspective on schools and transmission.
So there are a number of studies that have been done about schools that show that transmission happens in schools. There can be super spreader events in schools, and studies that show that estimated about 25% increase in transmission in when schools are open versus when schools are closed. And basically what that means is that you can go from a declining rate of cases in the community to either a steady or an increasing rate of transmission in the community based upon just opening schools or having schools being closed, allowing you to control the virus. So it's really a major contributor to transmission. And what we need to do in order to make schools safe is not entirely clear, but surely taking the risk of having schools open unless you have very low community transmission, and have done a lot to protect them is not a reasonable, successful strategy. And I just want to add one more thing as we're coming to close. One thing when you look globally is you see we've done all of the experiments. In Ireland, it's already enough to see what the pattern is if you don't go to elimination. But we've seen this already globally, that there are really two different strategies. One is the strategy to elimination, which has been successful in many countries. There's been many, over 1 billion people are safe, 1.4 billion are safe in communities that are celebrating holidays and with their families, and the economy is open. And we have the other part of the world, which is struggling just to get into a reasonable situation, which cannot be sustained. So given the experience, there is no doubt what is the winning strategy, and I really hope that Ireland will adopt it and join the winning countries and have a normal life to enjoy.
Thank you, Yanir. I see Oisín wants to get in there as well.
I don't say I'm an expert in schools, but what I will say is I went out and visited one school and just gave a talk to some teachers out there. And I suppose working in a healthcare environment, we have become extremely, extremely stringent as to reducing outbreaks in hospitals. In our hospital, you're no longer allowed to have coffee with any member of staff. So you can't even sit at the same table as another member of staff, unfortunately. So it is quite antisocial, but I think the difficulty with schools is you have to assume there are going to be clusters and outbreaks, and strong guidance needs to be given to teachers in terms of, unfortunately, staggering breaks, avoiding shared spaces, communal areas for teachers, and also gets back to the point of ventilation. I often say it's like cigarette smoke. If you can smell cigarette smoke inside in a room, it means it's poorly ventilated. Some schools are using carbon dioxide monitors to assess the static air and the buildup of carbon dioxide. And those kind of strategies need to be implemented in places where there are large numbers of people, because static air, and we now know that this is an aerosol. I mean, we all suspected it from March, but there's now even stronger evidence that this can remain in the air in static environments. And that's where the importance of ventilation, and also the importance of not, unfortunately, having coffee breaks at the same time and multiple people being in a same room. They're the kind of places that outbreaks are going to occur. And when the numbers of uncontrolled mystery community cases occur, that's when we're going to start seeing more and more outbreaks amongst teachers. And it will be inevitable that we will have a few of those events in the coming weeks and months, and that entire schools are going to be closed down, not just by the government, but actually because we will get an outbreak amongst teachers.
Thank you, Oisín. Yeah, so some very practical advice there as well. I'd like to now call on Professor Trish Carney, who's also going to talk about schools and some of the public health roles and responsibilities, I think.
Great, thanks, Aoife. So I just wanted to, I suppose, raise the point again about risks and rules, and that it really flags the need for political leadership. We know that when the economy opened up and people made the decision to go shopping, to go to the pubs, but they did so because they were facilitated to do so by the government. And I think it's important that we flag that's a political decision. I think within the Independent Scientific Advocacy Group that we welcome the decision to push out the opening of the schools, because while we absolutely consider schools an essential service and really need to be prioritised, the reality is that when there is high levels of community transmission, uncontrolled community transmission, which is what we have at the present, the schools may not be the safe place that we want them to be for our children and for our teachers. And so, like has been said by Gabriel and Oisín, we need to look at the evidence and the things that we can do to make schools as safe as they can possibly be. Thanks.
Thank you, Tricia. So we have a question also from Mark Paul of the Irish Times, who's saying, so in New Zealand and Australia, who have these zero COVID approaches and success. They have subsequently experienced some small outbreaks and then had lockdowns, I would say localized, regionalized lockdowns. And he's asking, how would we suggest that Ireland would handle such inevitable outbreaks? So I think, Tomas, you could take that question.
Thank you. This is a argument that's been brought up in the media in Ireland from a very early stage, which is, what's the point in going zero COVID or something near it, because the virus will just come back. And then people say, based on this reality, that there have been reintroductions, there have been seeding in Australia and New Zealand since they achieved elimination in the first instance, but therefore zero COVID or elimination doesn't work. And not to be glib about it, but it's a bit like saying that because a town has a power outage, that electricity doesn't work and we should all give up on electricity, or that we're not going to tidy our home because it's just going to get messy again anyway. The feature of the virus is that it grows exponentially, and this puts the population in essentially one of two bistable states. It's either growing rapidly or you have no transmission in the community, or effectively no transmission in the community. The rule of thumb in thinking about how to live and how to live in the pandemic is to get virus numbers down. When you get virus numbers down, you reduce damage to healthcare. When you get virus numbers down, you reduce damage to the economy. When you get virus numbers down, you reduce restrictions. And that's why travel quarantine is important, to prevent new cases from getting in. But when outbreaks happen, it doesn't mean that we all go into lockdown then for 3 months. If you have very small numbers, then your public health teams can respond to this locally with local restrictions, and to chase up and to crush any local outbreaks when they happen. And if you look at what's happening in New Zealand, if you look at what's happening in Australia, it's never been perfect. It's not been absolute zero, but it's been almost completely normal all of the time. Right now, they're celebrating New Year's, they're celebrating 2020 on the streets of Auckland without face masks. So if failure is what's happening in Australia and New Zealand, I think that's the kind of failure that I would like to live with. And the alternative is what needs to be put on the table. And the problem with the media narrative in Ireland is that we have not been comparing elimination or near elimination with the realities that we're otherwise facing. We've been comparing what this group has been proposing with a magical alternative. We've been comparing what this group has been proposing with, what if we found a middle way of opening up the economy while living with the virus? That was never really on the table. What we have as a baseline, as the status quo, is rolling lockdowns for most of 2021, being in level 5 and then level 3 and level 5 and level 3, or possibly with the new variant being mostly in level 5 or level 5 plus for most of 2021. That's the reality, that's what we're facing. What we want to do is to have one significant focused lockdown with a clear end goal, and then maintaining the country in level 1 restrictions or better. And yes, there may be local outbreaks, and yes, there may be more seeding, but we will be in a much better place to control it at that point. And to remember that it's not about getting to an absolute end goal. It's about having a program of suppression that is coherent, where the effort yields its own rewards.
Thanks, Tomas. Yeah, I think one of the key things is, when we say make this lockdown our last, it'll be the last national lockdown. And if a small outbreak did occur, then any restrictions could be very targeted and localized to really where the problem is. And the issue at the moment is the problem is nationwide, and it's totally uncontrolled. And the only thing we can do is a nationwide lockdown. And so every lockdown is avoidable if we take the correct steps, which is what we're trying to propose. So Jerry, I'd like to call on you. You said you wanted to contribute something with regard to schools and also the public health resourcing.
Sure, I think that question Tomas has just answered is a very astute one. And there's also a question I've seen here, but the resourcing of our public health physicians and their teams. What's more important than resourcing is the autonomy and the authority. There's no substitute for years and years of training and experience, knowing how to do outbreak investigation. I'm not qualified to do it. Most of us on this call are not qualified to do it. People like Ivan and Trish are, and I'd like them to comment. But I do know that our public health doctors have been sidelined. They are not, leading in terms of the policies and protocols we use for contact tracing and outbreak management. They're being given cookie cutter protocols, which we know are 9 months out of date. Our national contact tracing effort looks like it's designed like we don't want to know where transmission is coming from. And the difference between a specialist contract and a consultant contract is primarily about status. It's about the ability to make decisions without having to get it approved by somebody above you who is not as qualified to make those decisions. It's about letting the real public health leaders in this country actually lead. Now, there's only a few dozen of them, and why do we not hear from them? And I know from speaking to several of them confidentially that the only reason we have any good studies from Ireland that show us how outbreaks arise and how, like, for example, one couple infected over, what was it, 30 people over a weekend, is because they had to find loopholes in the protocols they were trapped in. They had to find ways to break the rules and trace people back. That's what they're having to do their own job. We need to set them free. And they're the people I'd like to be listening to on the NEFIT press briefing every night. They know what they're doing, and they know it from direct hands-on experience. Regarding the schools, one of the weird features about COVID epidemiology that makes it very, very difficult is that most people don't get very, very sick. Now, there are some people that are less likely to get sick, and therefore we see less of them in the data, particularly in relation to community transmission. Now, the obvious group there is school children. So if you look at our individual small bits and pieces of data, it's very difficult to see transmission passing through a school via kids. That will usually be documented as outbreaks in their households, okay? But rather than an outbreak in the school. But if you look at the international data examining the trajectories of, I think it was over 120 countries, when they analyzed the different effects, the different measures taken by countries have on their national trajectories, the second most important factor was closing schools, second only to stopping small gatherings, like primarily household gatherings. Thank you, Eve.
Thank you, Jerry. I'd like now to call on Gabriel Scally. We're very lucky to have him on the call because, in fact, Gabriel is the one who has written the reports on public health in the Republic of Ireland, and so has a very well-informed point of view.
Yeah, very well informed, but perhaps not all that an effective point of view, since the reports were ignored for so long. And I do feel that the time is now to actually implement what I and others have been calling for a long time. And I was in many ways reflecting the views of the public health community in the Republic of Ireland. And I always felt that their treatment and their positioning was disgraceful, but no more disgraceful than it was in the UK some time ago, and it was changed. I think one of the distinguishing things, and I absolutely agree with Tomas about what is necessary now. And as I said, I think the find, test, trace, isolate, support principle is of increased importance going into this period of time. And that requires good local ownership and good local leadership. And I have always been a fundamental supporter of the old medical officer of health, the director of public health, as it is known as these days, role. And I think that's one of the distinguishing features, I think, that has led to problems in Northern Ireland, in that in 2009, they abolished their directors of public health. There were 4, but they were abolished. And it's the only part of these islands that doesn't have local directors of public health of any sort in place. And that was a major error and has proven to be so. So I very much would like to see directors of public health in the Republic step forward into the public eye, provide leadership to their teams, have those teams and say what they need publicly to have those teams strengthened. I would like to see them given the resources to do this job now. And I would like a really strong commitment that the recognition accorded to public health will be the same and the respect and the recognition will be the same as any other clinical specialty. It deserves absolutely no less than that. In fact, it deserves a lot more in terms of redressing the problems that there are with recruitment. When you look at the age profile of public health in the Republic of Ireland, it is in an extremely precarious position. So now is the time, I think, for an immediate strengthening of the role of directors of public health, an expectation to those directors of public health, and I know they can do it, to step up to the plate and provide local leadership, and also a very strong commitment to give them the resources and the status that they need to be able to do their job properly. Now is the time for that to happen.
Thank you, Gabriel. I think I just go quickly to Ivan and then to Oisín, who wanted to come in on this point as well.
Yeah, just very briefly, I agree entirely with what Jerry and Gabriel have said. The public health consultant status issue, it's all about status and the authority to lead multidisciplinary teams. So we need to both resource the consultants, but also resource their support teams. I think that is key.
And Oisín?
I just follow that up. I mean, the fact that Ireland failed back in February 2020, when many of us on the ground were shouting for elimination strategies and our voices weren't being heard, is a sign that we didn't have a national pandemic institute. We didn't have resources and a national strategy to deal with something like this. I mean, elimination was what China told us to do in February 2020. And unfortunately, we've never resourced public health in Ireland to deal with a strategy such as this. And if we learn anything out of COVID, it should be that, one, there's going to be future pandemics and they're going to have higher R numbers and they're going to have even higher mortalities. And it's inevitable. It might be 5 years, it might be 10 years, it might be another 50 years before something like this happens again. But it was an absolute abject failure that Ireland didn't even entertain elimination, which was a natural thing. So many others, such as New Zealand, Australia, Taiwan, Japan, all of them went for that strategy from the get-go. And Ireland just didn't have the public health resources or mindset or infrastructure to contemplate such a thing. So I fully agree with what Gabriel says. This needs to be fixed long term.
So there's a wonderful, very highly renowned epidemiologist called Larry Brilliant, which is a fabulous name, who said that outbreaks are inevitable, pandemics are optional, and it's how you react to them. And I think we've demonstrated that this year. We've got ourselves into an awful mess. So there's a question here. There's a few questions, and then I think we'll wrap up because we've been here for a while. There's a couple of questions about vaccines. One person asking about, are there any recommendations about vaccines for the younger people and also for people who are immunosuppressed? And this person is specifically asking about rheumatoid arthritis. I don't know if any of the medics, I don't know if Anthony or Sam would have anything to say on that. Sam, yes.
Yeah, so those are really good questions. And I think we will hopefully know the answers in about 3 to 6 months as to which vaccines are more effective in specific subgroups of people, like the young, the elderly, or immunosuppressed. So I don't believe we have that information at this point, because the phase 3 trials, quite understandably, were done in healthy people, sort of 18 to 65. But inevitably, as we get more vaccines, I believe the Moderna one is now being used in the US, and the Oxford one has been sent for licensure, or at least emergency authorization in the UK. So I'm expecting we'll have 5 or 6 different vaccines, and some will work in different groups, and it will get more complex, but we just don't know that yet.
Jerry, were you raising your hand there, or did I? No, you weren't. Okay. So
you're muted, Aoife.
Classic 2020 move. So I think there's quite a few questions, but I think we've covered a lot of them. So a lot of people are asking about schools, of course. That's a challenge there, and of course, if we want schools to be open, we have to make everything else as safe as possible, so that the schools will be as safe as possible. People wondering about the vaccines, about the vaccine rollout, and all of these things. So I think we've been touching on all of these things, but I think it's about time that we wrapped up. So I'd just like to thank everybody for their contributions. Thank all of the audience for attending. And just to finish up with a slightly more optimistic tone, I think we've come here today to talk because we feel it's a very urgent message to get across, that we want to be able to get this message across. We want people to hear this because we're at a very important juncture right now. We have a choice right now for how we spend 2021. So we can either spend 2021 in rolling lockdowns, which I think we all agree at this point is miserable. It's not good for people, it's not good for business, it's not good for anything. Or we can make the strategic steps right now. We can get a strategy in place to open up our country internally for 2021. The cost is international quarantine effectively, but we need to do all of the things we've been talking about, use the lockdown to get the numbers low, resource public health, and then turn off the supply, the incoming supply. But this is something we can do, and we can have an optimistic outlook for 2021. We have had a wonderful year in many respects in terms of science. We've gone from a virus being unknown and first identified to the vaccine being designed, developed, manufactured and injected into people in a calendar year. This is extraordinary. So 2020 has been extraordinarily good in certain ways, and the optimism and that we can take from the progress of science is extraordinary, but we do have to give it time to work. It takes time for the vaccine to be delivered. It takes time for all of the necessary supplies to be manufactured, and we have a choice about how we spend that time until sufficient people are vaccinated. And what we really are strongly arguing for is that this lockdown should be our last lockdown. We need to take the steps to make sure that we don't end up in this situation again. It's utterly predictable. It was predicted before the second wave was predicted, the third wave was predicted. You saw earlier on the numbers that there is a fourth, fifth and sixth wave coming before the vaccine rollout is achieved, unless we take steps. So the point of optimism is this is in our control. There are things we can do, and we're trying to get the message out. We hope that you help us spread the message and talk to your TDs, talk to your public representatives. Do everything you can as well, please, to help us get the message out, because now is the time that this has to happen. So it's New Year's Eve. It's the last day of 2020. 2021 can be a fabulous year, not by itself. We have to take steps to make that happen, but those are totally within our control. So let's do that together, and let's make this lockdown our last. Thank you very much, everybody, for your attendance, and thanks to all of the panelists for their contributions. Bye-bye.